Hello, good morning, good evening, good afternoon, wherever you are in the world. And welcome to another VMR. Happy today to be discussing with our Alec and Mengyu. And today we have an awesome case presenter, Parisa. So please, Parisa, just unmute, introduce yourself before we get started to people that don't know you. And really looking forward to your case today. Thank you so much.
Thank you for giving me the opportunity. My name is Parisa. I'm international medical graduate from Iran. I'm happy to be here and learn from you.
Beautiful.
Welcome.
Thank you so much. Yes, and Alec and I are of Iranian descent, but sadly we don't speak any Farsi or anything like that. Where in Iran are you from?
What did you say?
Where in Iran are you from?
I'm from Tehran.
Tehran. Okay, very nice. Okay, well, yeah, I think we can get the whiteboard pulled up. We can go ahead and get started. Very excited for today.
Do you want me to start? I'm going to present the case in 5 aliquot and we'll pause after each to hear your thought and the amazing discussion. The first aliquot is a chief complaint, which is abdominal pain in 94-year-old female who is presenting to ER with a history of hypertension and atrial fibrillation. I'm gonna pause here.
Yeah, thank you, Parisa. I think that's a good start. I think the chief complaint is abdominal pain. So usually we can take an anatomical approach using kind of a clock as a location pointer. And depending on where the abdominal pain is, we can have some different differential diagnoses. And also we would have to consider some can't miss diagnoses for abdominal pain. For someone with hypertension, some cardiovascular risk factors and atrial fibrillation as well. I think like a mesenteric ischemia, if it's acute, it's something that we cannot miss, as well as things like rupture, obstruction, and infarction. So I think I'll just pause here and see if there's anything Alec and Austin would like to add.
No, yeah, I think you're thinking about it the same way I am, and I think it sort of see it already pop up in the chat. But I think whenever we approach anyone with abdominal pain, we're always asking ourselves, what are the morbid things that we can't miss? And we have this nice mnemonic, sort of the VIPO mnemonic, and I think that includes vascular, includes itises of any kind, perforation, obstruction, and then you could also include sort of gynecologic organs within that realm, though in a 94-year-old to sort of make that lower priority. I really like how you prioritize the maybe vascular phenomenon in this patient given their age and then the history of atrial fibrillation. So in particular, under the vascular bucket, we're thinking of some sort of thrombosis or embolism, as you're mentioning. So really interesting case. And I think the other thing I always ask myself whenever I see any sort of concern of pain is like, could this be referred from anywhere else? And in a 94-year-old, I was part of a discussion for one of the IMG initiatives in which they presented an elderly woman who presented with nonspecific symptoms and ended up having ovarian cancer. So I think just being open to the fact that as a 94-year-old, we have some sort of relative immunocompromise and at risk for presenting atypically. So I think I have to be open a little bit more to the possibility that this might not be within the abdomen itself. Though always a thoughtful consideration for anyone, but maybe just have my antenna up a little bit more. So excited to learn more. Alec, any final thoughts to add?
No, excellent breakdown by you and Mengyu. I think the extreme of the age, I think certainly, sometimes when it's in the mid-range or patients are young, we, use that less in the background, but I feel like in this case certainly would be relevant. And then I'm just wondering with that particular of the history of atrial fibrillation, oftentimes as people get older with atrial fibrillation, the chances that they're going to be on anticoagulation just goes down based off, the risk of falls and the risk of bleeding. And so sort of laying that into the background and getting a better history of what's been going on, I think will be helpful, but I have nothing to add to your expert discussion.
Okay, great points. I'm going to continue. In her History of present illness, this patient, as I mentioned, presented to ER and her pain started 2 days ago. She's scoring the pain 2 out of 10. Her pain is diffuse and the nature of the pain is dull and colicky. Pain is not radiating anywhere. She hasn't eaten anything since the symptom started. Her symptom is also associated with nausea, bloating, and the absence of bowel movement. In her ROS, she does not have any associated chest pain or shortness of breath. She's not reporting any history of weight loss, and she denies any blood in her stool or any black stool. She does not have any dysuria or frequency, but as long as she remembers, she was struggling with constipation. In terms of her diet, she's mainly using processed ready-to-eat or microwave heated foods with less amount of vegetable and fibers. She's independent with her activity of daily living. In her past medical history, she has the hypertension. She has heart failure with preserved ejection fraction. She also has hyperlipidemia. She's also has chronic kidney disease, stage 4, G4A3. She has AF and she also has a history of uterine fibroids. In terms of her medication, she is getting hydralazine, clonidine, and irbesartan. For hypertension, she's getting carvedilol and furosemide for her heart failure and atorvastatin for her hyperlipidemia. She is not getting any anticoagulation for her AF. In terms of her family history is negative, and her social history, she is non-smoker, non-alcoholic. She does not have any significant travel history, and she does not have any pet at home. I'm going to pause here to hear your thought.
Yeah, I don't know how we want to do this, Austin. Maybe I can take a stab at the HPI part, and then you can take maybe make additional comments, and then kind of comments more on the past medical history. So yeah, so the symptoms of this nausea, bloating, and the absence of bowel movements almost make me think of obstruction. And I remember there's this framework about where the obstruction is. If it's more in the upper GI tract, then you would have more significant nausea and less of bowel movement problems. Versus if it's lower, then the bloating and nausea will be coming a little bit later, but more constipation. So and potentially more abdominal pain. It kind of struck me that the abdominal pain is pretty mild, but the diffuse nature, I think, more points towards it could be somewhat non-specific, but could be like a bowel problem. So like a colonic obstruction. It's something that came into my mind, given the symptoms described, which in an elderly people would think of things like cancer. Although the fact that she has no weight loss would, not rule out the diagnosis, but kind of makes it a little bit maybe suspicious. Other causes of obstruction, we could consider, like if it's a slow vascular process, like a mesenteric. So instead of mesenteric ischemia, I could think of chronic bowel ischemia, like could slow down the bowel as well, causing a kind of a ileus picture. And I like some of the comments that actually observed in the chat about the fact that she's eating processed food and not a lot of vegetable or fiber, which kind of agree that brought up concern for certain vitamin deficiencies like vitamin C deficiencies and scurvy. And I don't have a strong unit script for scurvy. I know it causes like bleeding and kind of skin or mucous membrane fragility. Wonder if it's abdominal pains part of the unit script. But yeah, I'll pause here and see if Alec has anything to that, and the other analysis of the other part of the case.
Yeah, no, I think you outlined a really brilliant discussion about, how you're taking the information from the HBI and trying to localize it, and you really anchored on or focused on the sort of lack of bowel movements and the relative proportion of pain to the amount of nausea to say, hey, I think I'm in the lower GI tract as opposed to the upper GI tract, or the large bowel as opposed to the small bowel. And I'm right there with you. I think, and you already did such a nice job talking about that. I don't think I have too much to add besides saying, we also have the symptom of sort of bloating now to help us support, maybe help characterize the abdominal pain. And, Reza has a very nice approach to bloating that I like as the states of matter. So like solid, liquid, and gas, and sort of laying that on top of what you've already discussed. I think we're either in the gas picture or the liquid picture here. But, certainly, this patient is going to be getting imaging of some kind, and that'll help us make some progress. But if I take the medical history and focus on the constipation in particular right now and say, okay, how much do I need to read into this presentation to the constipation in someone that's 94 years old? And I'd say based off the base rate, in clinic, constipation is so common. And as we get older, idiopathic constipation is so common that it's really hard to say that this is signal rather than noise. She probably has just chronic constipation and maybe it's not related. And the foods, could contribute to the constipation for sure. But I'm not sure if I'm able to in the absence, if this wasn't a clinical reasoning exercise, I would say, hey, I'm not really sure what to do with that information right now, but I'm sort of keeping track of it, but saying that the base rate of constipation is so high, and diet in the United States, which I believe this case was in, this is not an uncommon diet that people eat. So I'm uncertain how to really make diagnostic progress with that. However, if I approach this from a clinical reasoning case standpoint and say, hey, okay, this patient has HFpEF, they have CKD, they have GI dysmotility, and now they're presenting with abdominal pain. Could they have some sort of infiltrative disease to link everything together? And in particular, I'd be thinking about something like amyloidosis, for example. But I think I'm reaching a little bit there. But I think that would be a very, very interesting train to go down, depending on what the rest of the history shows, and as we clarify the sort of clinical picture a little bit more. I guess I would leave Alec to talk about any other comments in general, and then to go through the medications. I think some of those are interesting to look through as well.
Well, Austin, I think that was amazing that you were able to link together all those, really subtle symptoms, but also, recognizing the base rate that she's 94, she has a long-standing history of hypertension, which could very well explain the HFpEF, and then same thing with the CKD. But I think anytime you see CKD, always good to ask why, right? Why do they have CKD? I think oftentimes we just assume, oh, it's from the diabetes, oh, it's from the hypertension. But, as Robbie has mentioned numerous times, primary hypertension causing CKD is less and less likely to actually be the case. So I think getting some more history regarding that, I think, is helpful. But layering in the background on how it's all maybe linked, I think, is key. And then as far as the medications, certainly some of them are interesting. I don't associate lots of them with constipation per se, or maybe some of her other symptomatology. Clonidine, maybe, she is on furosemide. Could that just predispose her to ongoing volume depletion and make her more likely to have constipation as well in combination with her diet also? And then, irbesartan is associated with like a sprue-like enteropathy, but we're not getting that sort of history here either. But I think that her symptoms, I agree with you and Mengyu that it seems more likely to be intraluminal. And, vascular is still a thought, particularly the fact that she's not on anticoagulation. But I think it would be good to know, does she have a history of AFib? Is she actually still an AFib or not? And then, just as a teaching point, I like to share with my learners is, oftentimes we have this conversation about, elderly people using anticoagulation and when the risks outweigh the benefits, and, how many times does somebody really have to fall before the risks of a subdural hemorrhage or an intracranial bleed outweigh the risk of anticoagulation to prevent a stroke? And it's unique, but there was a study in JAMA out of the 70s that you have to fall 300 times for the risk of an intracranial bleed to outweigh the prevention of a stroke. And that was when they were using warfarin. So I think you have to think about it on a case-by-case basis, but sometimes we overdo it. But I think it's something we need to track, but I agree. It seems like she's had probably longstanding constipation. So getting a sense of as well. Like, is she passing gas or not? Sometimes like having a bowel movement every 3 or 4 days may be normal for that person, right? But if she's like, oh, I haven't been having gas either, and I have distension, I think even more, the center of gravity shifts something intra-abdominally, particularly intraluminally. And then I think other people have mentioned in the chat, but there's other systemic things that could be going on, particularly hypercalcemia with this dementia, but we don't necessarily know the time course. Could she have some altered mentation that could explain some of the symptoms as well? But I think I'm right there with you. I definitely think cross-sectional imaging will be important, getting a sense of is she passing gas or not, and then getting a sense of why behind she has CKD or other things, I think will be important. And yeah, looking forward to learning more.
Okay. Do you want me to continue? Okay, a great discussion. I'm going to give you the vital sign and the physical exam. Her vital sign, the blood pressure is 184/85. Heart rate is 100. Respiratory rate is 18. Her temperature is 37.5. And she's saturating 99% under room temperature. In her exam, she's an elderly woman sitting in the bed, and she is not in acute distress, but she's a bit restless. In HENT, there is no redness or swelling in her eyes, no pale conjunctiva, and onycteric sclera. Her oral mucosa is moist. In her cardiovascular, there is irregular rhythm. S1 is normal and S2 increased intensity. In her pulmonary exam, there is no wheeze, no RAL or rhonchi. Her abdomen is distended. Bowel sound became hypoactive. There is mild diffuse tenderness to palpation. There is no surgical scar, no peritoneal sign, and no sign of hernia or rash. In her neural exam, she is alert and oriented to person, place, and time. She has appropriate mood and effect. And in her extremity, her extremity is bilaterally symmetric tone, and there is no motor or sensory deficit. In her lab data, her hemoglobin is 14.5. Her white BC is 3.73. Platelet 155. Her metabolic panel, sodium is 135. Potassium 4.4. Color 100. Bicarbonate 28.6. Her BUN 37, creatinine 1.67, 1.67. Her GFR is 28. Her glucose 119. Her phosphor 5.1. Magnesium 2.4. 4.1, magnesium 2.4, calcium 9.4, and her lactate is 2. Her albumin 3.8. Total protein 7.2. Alkaline phosphatase 61. AST 26. No, 26. And ALT less than 9. I'm going to pause here to hear your thought.
Yeah, Parisa, such a wonderful presentation so far. You made the case really intriguing. Austin or Alec, I don't know how you want to, should we alternate our discussions here, or do you prefer I still go first?
No, just keep going. You're doing great.
All right. I feel like it's almost a little bit easier for me to go first, and then you can add an additional thing. So yeah, yes, I think what caught my, maybe I'll focus on the physical exam. So what caught my attention is the vitals at first, because the temperature is I mean afebrile, but not completely normal. It's like anything like above 37, 0.5 always make me take a second look. And the heart rate also is high, which makes me think about the severity or acuteness of the presentation, is if there's something like sepsis brewing, or is the underlying process going on. And the blood pressure being high, it's a question of, I mean, I'm glad it's not low, but also it's a question of whether that's her baseline high blood pressure, not maybe she didn't take her medication because of the illness for a couple of days or something like that, versus it's a reflection of acute stress. So yeah, and then in correlation with the other part of the exam, the abdominal exam just confirmed the acuity or the worrisome feature of the case, which is the fact that it has diffuse tenderness. Not sure if there's a rebound. If that's the case, that would be even more concerning. I would need an image immediately, but still the diffuse tenderness is somewhat concerning. And then the hypoactive bowel sounds kind of correlate with the history of decreased bowel movements. And again, curious if the patient has not passed gas as well, which then would allude to a constipation or even obstruction. I mean, especially obstruction. So in which then the differential would include a bunch, which some of those were brought up before. But again, I think having an imaging here is going to be very helpful to help us understand the distension, whether it's, as Alec mentioned, whether it's due to fluid or stool or gas, and the lack of bowel movement kind of points towards a stool or a gas from ileus. Yeah, I'll kind of pause here and see what Alex and Austin said.
Yeah, no, really nice discussion. And yeah, my takeaways from the physical exam itself was the patient, is AFib. We sort of confirmed that that's still ongoing for them. They don't appear dry in the physical exam, and the abdomen, was diffusely tender, but it doesn't seem to be peritonitic, at least from what we've gotten right now. So I'm not sure really changed our probabilities or our differential diagnosis of what we were thinking right now. But if I look at the vital signs a little bit more, the hypertension strikes me. Like, we know she has a history of hypertension, but she is on multiple agents. So, understanding the patient's level of control will be interesting. Maybe this is a manifestation of pain itself, but what's remarkable is she has a pretty wide pulse pressure of around 100. So, as we get older, that we can certainly have a wide impulse pressure, but it would be nice to know maybe some prior baseline levels to figure out if that's signal or noise. And then, looping in the heart rate of around 100, she is on a beta blocker as well. So is that signal of portending a badness as well? And we're just sort of masking part of that because of the beta blockade. I don't want to overinterpret the vital signs, but, those are some things that stuck out to me. As far as the blood work, I think looking at them in general, I'd say that, having a baseline creatinine will be nice, but it seems like this is pretty what her baseline should be based off the history of CKD, as far as the metabolic panel itself. The CBC is interesting. It'll be interesting to see if the white count is baseline. She has sort of mild leukopenia, a hemoglobin of 14.5, and someone that's 94 and has chronic kidney disease, and chronic illness is a little bit higher than I would expect. So I'm not certain if that represents signal in and of itself, whether that's a secondary polycythemia. We didn't get the patient's BMI or history. They didn't really have a prominent history of metabolic syndrome, at least so we can see thus far. Maybe they do, but maybe that could suggest that there's a secondary cause, or if we're invoking the possibility of some sort of vascular phenomenon, then we'd have to consider something like polycythemia vera or something like that. That would be unlikely compared to all the other signal we have. I think those were the main thoughts I had. I think I'll leave Alec to interpret the rest of the blood work that we have, or any other thoughts he might have.
Yeah, thanks so much, Austin and Mengyu, for sort of the alley-oop there. And yeah, I just want to say, it is shocking that a 94-year-old woman has a normal hemoglobin. Especially with her diet, seems to be entirely predisposed to many micronutrient deficiencies. she has likely advanced CKD. It's abnormally normal, and especially in a combination with leukopenia, I do wonder about something going on with her bone marrow or the potential to have polycythemia as well. I mean, her platelets are on the lower end of normal, so something to track as we go forward. And then, yeah, I mean, I think from the way Parisa has presented, it seems like probably her BUN and creatinine are probably at her baseline, and we can confirm that later on. The lactate being normal, as we continue to think about the possibility of mesenteric ischemia, particularly in the setting of chronic mesenteric ischemia, this lactate can be normal. If you're not hyperperfusing and the bowel is dying right in that moment when you check the lab, it's not a sensitive enough test to just exclude that diagnosis. Now, I think our presentation seems somewhat less consistent with that, but it's just something that we're going to need to consider and just recognize that our lab tests are imperfect. And she has abdominal pain, a little bit of distension, thinking about hepatobiliary causes just based off base rate. Certainly the lab suggests that to be a little bit less. We didn't have a lipase, but presumably it was okay. And I think, as Austin has called it, before, she just needs to go to the tube of truth to get a sense of what's actually going on with her abdomen. And, as Robbie mentioned so many times, particularly with abdominal pain, there aren't that many cases where you don't need a CT scan. And I feel like in this case, you would. And for her, with the things going on, you need the study with contrast. And I don't, it's more important to track her CKD, but recognize that, there is some controversy around this, but the idea of, having CKD, does intravenous contrast really increase your risk of contrast-associated AKI? And I think the data would say that it's sort of out. But it's more important to, I guess, what's going to harm the patient first, right? A mesenteric ischemia or some contrast, and you need to confirm your diagnosis. So don't do an inadequate test just because you're concerned about a possible downstream effect. So maybe that was mentioned in the chat, but just something I wanted to highlight as well. And then her going back to her blood pressure as well, high, but I agree that her age, that pulse pressure may be normal for her. And then important to get a baseline, but she is on 2 antihypertensives that are very well known to cause rebound hypertension as well, if she's just been in the ER and has been that without them. So just something to track also. And yeah, I mean, I think as well, especially with that degree of hypertension and having abdominal pain, also need to think about dissection. I think her presentation is less consistent with that, but it's not a diagnosis you would want to miss. And the CT will also assist us with that. But I don't know if the calculus or the differential has changed all that much. I still think we need to consider an intranumeral pathology, and the CT will hopefully point us in the right direction going forward. So I'm looking forward to hearing more.
Thank you. Great discussion. I'm going to share her EKG and the abdominal X-ray and the CT scan. Are you able to see my screen?
Yes.
This is her EKG.
So I think just looking at the EKG, I think first confirm that she is still in she's in atrial fibrillation, and kind of a normal rate when it's between 3 and 5 blocks between RR, and normal access when I see both 1 and 2 are up, and hypertrophy wise not significantly, given the combination of amplitudes in the anterior leads are not more than 7 blocks, and then the AVL is also not that tall. And then we kind of focus on STT changes, also QRS there also no block. So STT changes wise, I don't see anything significantly jumping out as ischemic. I think the quality is a little bit limited. But I'm trying to just scan to make sure there's I don't see, there's some T wave, kind of biphasic T waves in the V4 leads, but I think it's overall V4, V5, but overall I think it looks kind of unremarkable, just seems to be consistent with the AFib.
Yes.
Do you agree?
This is the first X-ray, which is consistent with the finding of a small bubble obstruction.
Wow.
And
Yeah,
this
it's like
one,
it's swirling. I don't know if it's like a volvulus or anything like they commented like that, but yeah, it looks kind of pretty impressive.
Yeah, and I think in the pelvis, are those calcified fibroids or okay.
yes. And this one is also her CT scan. All the internal organs were normal except a small bubble, which has diffuse dilation and the loops measuring up to 3.5 centimeters. Clear transition point is not evident, probably in the pelvis. She has colonic diverticulosis without diverticulitis. There were impacted stool in her rectum, and there were trace ascites in the pelvis. And she also have a small right pleural effusion.
Yeah. Yeah, since no transition point is seen, I wonder. So Parisa, could you remind me again if the dilution is all the way towards the where the stool the rectal stool collection is, or is it more proximal? Like, is there like colonic? It seems like there's colonic dilation as well, right? Is that what you said?
Yeah. The report is saying that diffuse dilation after small bubble loops measuring up to 3.5 centimeter.
I see. So it's kind of focused on the small bowel loop. Yeah, I think then the question is, oh, sorry. Do you have more information to give us, or are we?
No, I will tell you the scenario and her hospitalization after you discuss these findings.
Gotcha. So maybe Alex and us now make some initial comments about the imaging, and then you can take over. So I guess it's not surprising that the patient has stool burden and rectal kind of constipation, which correlates with the history. But I'm trying to reconcile if the small bowel dilatation obstruction could be just explained by that stool burden, or is there something else going on? Because I imagine if there's a lot of stool, depending on how much stool it is in the colon, you would also see some colonic dilatation, which I thought there is, but maybe not, because I thought I see some pouches. But if it's just small bowel, then I would wonder if there's a process in the more proximal, maybe at the junction of small bowel and large bowel, or somewhere proximally, or like a pathology. But usually if there's like volvulus, you'll be able to tell on the imaging. It was pretty remarkable. So it doesn't sound like there's that. And then like the pathology, if it's a cancer or like a colon cancer or some tumor, it may not, the imaging may not be the best test for that. And colonoscopy kind of is a more sensitive test, I think. And I think also, I think I'll pause here and I'll think a little bit more about how to yeah.
Yeah, no, great initial discussions, and thanks so much for taking the lead. It definitely makes Alec and I's life a lot easier, and so thanks so much for stepping up on that. And I promise that we'll switch roles in one of the future VMRs. But yeah, I mean, I think if I start back at the beginning with the EKG, I think it makes sense, why they got in the beginning, and the patient is tachycardic. They're having abdominal pain. Could this be referred pain? Could this represent, myocardial ischemia, something like that? So I think it was reasonable to obtain for sure. And then, as far as what it looked like, I agree. I didn't see anything that seemed obviously ischemic to me, acutely ischemic, I should say. In her septal leads, like V1, V2, she does have some pretty deep Q waves. So I'm wondering if she maybe had a prior MI. But that would be something to track. And then, her access was sort of like borderline deviated. But to your point, besides she was in atrial fibrillation, so it would be hard to comment on like any other conduction disease that we saw there. That didn't seem to be reduced amplitudes compared to what we would expect, if we were considering an infiltrative disease, as we discussed before. So not too exciting for a 94-year-old with known atrial fibrillation, at least from my amateur read. But, I agree with you completely otherwise. As far as the X-ray, I'll argue with you that in the United States, in resource where resources are plentiful, abdominal X-rays in 2023 are tests that we should not be doing in someone that has this type of clinical syndrome. They are low value care, and then there's actual something about things we do for no reason, talking about abdominal X-rays in the United States. So, not to say that they don't have a role, not to say that it wasn't potentially helpful here, but it doesn't move the needle enough for us not to obtain a CT scan. And I think if we're going to obtain the CT scan anyways, oftentimes we can get it. Unless it was like hyper acute, urgent, probably we'd be able to get it within a reasonable amount of time, similarly to an X-ray, depending on where you work. I don't know about your X-ray test at your hospital, but I think you could make a strong argument in the United States that we should not be performing abdominal X-rays anymore. If you're that worried about someone's abdomen, you should get a CT scan because it's a better test. But as far as what we're seeing, I agree. I don't really see, the colon looks a little bit dilated to me. Looking at the walls that we can see here, it doesn't appear like there's inflammation or that the walls themselves are thickened. So I think that's, to your point, maybe we're just seeing dilation from the stool burden itself, but clearly the small bowel is definitely enlarged. And so, as was raised in the chat, why should we? This person has a small bowel obstruction that we've, anchored on at this point. So why does the patient have a small bowel obstruction? And, expertly, Parisa mentioned that the patient has never had a history of abdominal surgeries, and there was no evidence of prior surgeries on their physical exam. So the most common reason why someone has a small bowel obstruction is adhesions that we think about, right? So what's the most common reason why someone without a prior history of abdominal surgery has small bowel obstruction? And I learned only recently that the answer is still adhesions. So it's the most likely this patient probably has an adhesion. We didn't see a clear transition point, but it doesn't mean that it's not there. There seems to be a lot going on in the abdomen. And so, maybe the patient had a history of some other inflammatory syndrome within the belly, and that led to adhesions, or maybe it's just completely idiopathic, or maybe there's something within the lumen or the wall that we can't see on the imaging that maybe intraluminal observation with an endoscopy would make sense to do. But I think right now we're sort of management over diagnosis. Say, hey, we need to treat the small bowel obstruction, see how things decompress, maybe repeat the imaging following that, and then decide, of course, in coordination with her goals of care and her family, or if she's able to make decisions for herself, decide what we want to do for her. But I'm not certain we'll be able to find exactly what's happening, right at this moment in time. If I think, sorry, there's something else I was going to say, but it's completely slipped my mind. So maybe Alec, why don't you go? And if I think of something again, I will chime in.
Yeah, great thoughts, Mengyu and Austin. I think something that I'm struggling with a little bit is, are we going to call this a partial or a full small bowel obstruction? And she does have air in the rectum. So either it's just left over from prior to when the obstruction occurred, or there's still a small amount passing through, and up to 3 centimeter dilatation of the small bowel can be normal, and it is above that. I think also to recognize, just looking at the image, it seems like she is a very thin woman. And just if you have a little bit of, she has less fat peripherally, but you also have less intra-abdominal fat. And that makes the possibility of seeing fat stranding or significant inflammation around the intestines a little bit harder, because everything's just kind of smushed together right now. And so I think it makes it a little bit hard to tell. And, I think Austin and Mengyu did a great job sort of saying, yeah, right, we need to figure out why she may or may not have an SBL. And is it intraluminally, either from a lesion or inflammation from whatever? Is it extrinsic, either from a mass somewhere else in the pelvis or related to the sort of intestine itself? Or I was just trying to, I'm going back to the AFib or not. Is there a way that we could link some sort of vascular thing leading to a bowel obstruction? And I imagine if you infarcted part of the bowel and it died, you get inflammation that could do it. Or, for example, if you infarcted the spleen and it got big and was pushing on the bowel, you could think about that as well. But I don't clearly see that on the images provided. So I mean, honestly, in this situation, I would probably just try and treat her constipation. Maybe something from below, maybe consider placing an NG, and sucking things out, see how she feels, and trying to get her bowels cleaned out and just repeating the imaging and seeing what it looks like. Because I think really right now it's really hard to tell based off the pictures alone what exactly is going on. So obviously you have to be concerned about the risk of perforation, other things being aggressive with the bowel regimen. But you can do these things with a fine, balance and in consultation with the experts. As far as making more diagnostic progress, if there's additional testing or imaging that I would want done, I don't know. I mean, I think she does give a strong history of constipation, and I imagine we could treat that, best we can, and then reassess following that. As far as jumping straight to endoscopy, either below or above. I don't know if we need to do that now, but just to clarify with Parisa, was this the last aliquot prior to revealing the diagnosis?
Yes, I'm going to keep in the last aliquot, I will talk a little about the history of her admission and the things happened after she admitted.
Okay, so it sounds like we gotta try and figure out what's going on here. I think in short, the imaging shows small bowel dilatation, significant constipation, but I'm not seeing a lot of other sort of signal of inflammation in the belly otherwise, but that just may be because she has very little intra-abdominal fat. And my argument would be to try and treat the constipation and then reassess and then go from there. But I may just be missing things in my illness script. I'll just say in my clinical practice, I see a lot of older patients, a lot of patients with constipation. And a lot of times the management of small bowel obstructions, partial or otherwise, is just very much supportive. And sort of, watching the lines of clinical assessment. And then if people aren't improving the way that you would expect, working with your gastroenterology and, frequently surgery colleagues to figure out what to do next is usually the next step. But, her vitals are stable. There's no evidence of peritonitis. We don't see any free air in the abdomen, which is, useful on the CT scan as well to make perforation a little bit less likely. But I'm excited to learn more. But Austin and Mengyu, any sort of closing thoughts before we Parisa educates us on such a great case?
Yeah, great thoughts, Alec and Austin. Yeah, I kind of agree. I think for small bowel obstruction, I think my next step in reality would be to review the imagings with radiologists to look at the site again, see if there's any clues, and then also consult surgery for the next steps, which usually includes like conservative management, like NPO, NG tube if there's vomiting, or maybe NG tube just for decompression, NPO, IV fluids. And then I also kind of agree that helping with the constipation, like maybe some rectal laxative would be helpful too. See if that would help improve some of the symptoms. Yeah, and I don't have any like a confirm like a certain cause. I think maybe in the meantime we'll work up for some of the causes of bowel obstruction, including like autonomic function workup, kind of amyloid. I think some of the labs already ruled out some earlier differential diagnosis. But yeah, I wonder what Austin, you think?
Yeah, no, not much to add to everything. The only thing I finally remembered I was thinking about was the free fluid in the abdomen of a small pleural effusion. Like, how do we explain what's going on with that? And I think to Alec's excellent point, I didn't scrutinize the CT scan enough to say, wow, this woman is really thin. Does she just not have, fat to strand? And that was a teaching point that I learned from Robbie a few years ago. And, I think that the presence of free fluid is not uncommon in someone that has a bowel obstruction. And so could that just be tracking up the sort of right diaphragm area to cause a pleural effusion, or could that be reactionary from inflammation in that right upper quadrant area? Maybe that's where a transition point or the pathology is, but it's such a reach. And then, she also has a HepPEF, so maybe she could have pleural effusion related to that. So hard to say, but yeah, really excited to learn more and thank you so much, Parisa, for presenting this excellent case.
Thank you for mentioning all the great points. In the last aliquot, I will tell you the story of her hospitalization. She admitted to the general surgery service, and initial fluid therapy was started, and she was made NPO. Unfortunately, on her second day of admission, she became deteriorated, and she was noted to have worsening of abdominal pain and distension. Her serum creatinine was rising to 2.72. Although fully was ordered for her, her daughter was declined to do that. And accordingly, her lactate was trending up to 4.9. She has one episode of bowel movement, and after that, she developed syncopal episode. Her mental status deteriorated, and then she developed 3 episodes of MSCs. All the services were consulted, and following multidisciplinary code status, where the decision made to transition to do not resuscitate, do not intubate. afterward, the patient experienced bradycardia and hypotension, and unfortunately, she passed away. I also have another CT scan of the 24 hours. I'm going to share that with you also. It is the last CT scan.
So I think, yeah, to Alec's point, we're now seeing air in places that it shouldn't be. So definitely concerning for, but with the rising creatinine, the lactate, definitely worried about some dead gut and perforation. And so you can see air within this, looks like the liver, and as well within the bowel wall. So yeah, very unfortunate case. But so much learning. So, thank you so much for sharing this case, Alec and Mengyu. What are your thoughts?
Yeah, I mean, I agree. Sometimes on the CT, it's really hard to tell, especially in the liver there, is the air in the venous system or is it in the biliary system? But I would argue it seems like the air is in the wall of the colon and in the colon, speaking to the ischemia, and then probably just I would imagine it's in the venous system and just speaks to sort of dead bowel. Don't see a lot of free air under the diaphragm, so like a massive perforation seems less likely, but it seems like maybe she came in and she did have some ischemia and we just caught it a little bit early, or it just infarcted more and more and more and the collaterals just sort of died off, and then unfortunately we reached this point. And very sad case, but a lot of great learning that we got from this case. And I want to thank Parisa for an expert presentation. Wouldn't have known it's your first time, and I think it was really great to sort of reflect on this and to sort of better expand my illness script potentially for what I think is probably related to ischemia of the bowel, but I'm hoping that you confirm that. Yeah, Mengyu, what do you think?
Yeah. Thank you, Parisa, for such wonderful case presentation, and also feel sad, unfortunately, for the patient about the outcome. But I was thinking when you said the patient clinical status got worse, despite the conservative management, I was thinking, if it's a younger patient or maybe less comorbidities, would have gone to surgery for a small bowel resection, because I think small bowel obstruction, if not under control, could lead to complications like this. And as Alec also mentioned earlier, I think also agree, like there's air in the portal vein, seems like, which indicates, like a rupture of or ischemia. So which could be a result of the severe small bowel obstruction. Yeah, I think that's what I'm thinking right now. Parisa, any final information or comments, or what it feels like?
I personally really liked this patient, as I know the final diagnosis was a little obvious, but I really like the process of thinking and how you all mentioned the different possibility and how you narrowing down all the differentials. Because for me, I'm usually thinking an elderly with non-specific symptoms, she might have extremely wide of possibilities, and you really beautifully narrow everything down to come to the final diagnosis. And I learned a lot from you. And I really like the way you were layering also down the CBS ischemic abdominal pain diagnosis. It was really great discussion, and I learned a lot from you. Thank you.
Yeah, thank you so much for presenting this case very expertly and brilliantly. It was so well planned out and laid out. So thank you so much for your hard work on that. And I think we're on to Debbie for the teaching points.
I need to establish.
Hi everyone. I'll just summarize some of the teaching points that the case of today can give us. First of all, the Cadmi's diagnosis in a patient with abdominal pain and vascular risk factors such as this one could we could miss the PITO mnemonic vascular risk factors and think of first of all mesenteric ischemia and also MI. It's important in these cases in older patients to don't forget asking why does the chronic conditions, what are the causes of the incorrect conditions, and we also learned some pearls. I'll take some of them, such as that were posted in the chat, such as that the abdominal auscultation is not very useful and has very low levels of inter-observer agreement, except for trying to rule out obstruction. In this case, normal bowel sound has a likelihood ratio of 0.4. Also that the normal lactate doesn't rule out mesenteric ischemia, such as this case remind us. It was also mentioned that abdominal X-rays are things I think we do for no reason in patients with abdominal pain, and does move the needle enough if we have access to a CT. There was a great discussion of the causes of small bowel obstruction, and some of these are summarized in the whiteboard, and we learned that the adhesions are the most common cause, even if no abdominal surgery was done in the patient. And I rescued this pearl from the chat from an article that was shared by Austin, that the temporary resolution of abdominal pain in patients with chronic mesenteric ischemia can be an ominous sign that signals towards the transition to acute and chronic mesenteric ischemia, and doesn't have to relieve us, but to worry us. And well, that's all. And thank you very much for the case.
Thank you, David, for the awesome teaching points. Well, I think we can conclude the case today, and hope everyone have a great day.
Thank you.
Take care. Bye.